76% of people with irritable bowel syndrome have small intestinal bacterial overgrowth. We're going to talk all about that today, but we're really going to dive into a new testing methodology that we use with our patients and has really increased accessibility, ease of use, and all things in terms of treating SIBO when it's associated with irritable bowel syndrome. We're here with Dr. Natalie Sheeler from Modern Med, who did a deep dive into this and uses this device with her patients as well. So we're going to start, but first by setting the groundwork and talking about small intestinal bacterial overgrowth in general. We have a bunch of videos on this, so if you're not familiar with the topic, please go back, look at all of them, and we do deep dives in those videos. We're going to do a general overview right now just to get the foundation so we can talk about the actual testing, but I'll let you start.
Awesome. As you said, SIBO stands for small intestine bacterial overgrowth. And just as a brief refresher, for our digestive tract, we have our stomach that feeds into our small intestine, and that feeds into our large intestine, aka the colon. And when people are talking about the microbiome, we're largely typically referring to that large intestine because that's where the majority of the bacteria lives in our gut microbiome. However, there is a relatively small amount of microbes in the small intestine, and for a multitude of different reasons, we can see that there is overgrowth of those microbes that are typically present in the small intestine, or we can see microbes that are typically common in the large intestine, in the small intestine, where they're not usually found. So when we see that, we give the diagnosis small intestine bacterial overgrowth. That is the general overview there.
Yeah. And I so badly want to ask you a bunch of questions about it, but please go to the other videos because we've already covered it. We want to focus on more of the testing modality, but just general symptoms somebody would have if they have SIBO.
Yeah, the classic symptom that we think about is bloating and abdominal distension. We see either constipation, diarrhea, sometimes both. Other symptoms that people can experience is having increased gas, increased flatulence, belching, dyspepsia, so indigestion, some upper GI fullness symptoms there. And those are the kind of classic symptoms that we think about when we hear SIBO.
Yeah. And one of the keynotes, which is usually there, but not always there, is you wake up and you don't feel bloated before you start eating. And as the day progresses after meals, you get more and more bloated. And by nighttime, you feel like, some people will say, oh, I feel like 9 months pregnant, or my stomach is distended. They go to bed, they're fasting during that time, they wake up and they have less bloating / flatter stomach too.
Yeah. And I do too think there's a little bit of a spectrum too, that there's some people who can even drinking water can set off the bloating. Others people, it's specific foods that they tend to react more that will trigger that bloating.
Oh. Standard testing for us to look for this. And let's just talk about what we did before this device came around first.
Before this device came about, the most common that we're using in GI offices or offices now is a lactulose breath test. Lactulose is essentially a sugar. We consume that sugar and then we collect breath every 15 to 20 minutes for about 2 to 3 hours. And in that breath, we're measuring the gases, and we're using the gas as an indirect measure for the level of bacteria throughout the digestive tract. So when we consume that sugar, it moves through our digestive tract, it feeds the bacteria produced gases, they are absorbed into our blood, and then we exhale them through the lungs. So when we collect that breath, we measure the gas, and we use that as that measure. So that's the most common method for treatment nowadays. Prior, the gold standard for SIBO testing was considered a duodenal aspirate, which duodenum is just the upper part of the small intestine. And so what they would do typically during an endoscopy, which is when they are taking the camera into the stomach, upper part of small intestine, they would collect a sample there, and then they would test that sample for what microbes are present. And that was the previous gold standard. We no longer hold that as the gold standard because there are some pretty significant limitations. First off, it is invasive. It's hard to do. It's not something compared to just blowing in tubes and collecting your breath. It requires a procedure. The other thing too is it's taking from the upper part of the small intestine. So that misses the middle and lower part of the small intestine, which is where we commonly see this overgrowth. And we can get a false negative and miss it entirely. And then last, there's an issue with contamination of keeping that sample clean as we go to test it. And so we don't do that as much, but that at one point was the gold standard.
Yeah, and just accessibility, having to go into a procedure room and the cost of it and that whole thing definitely is not what most people are doing right now. And even I remember back when I did my first SIBO test as a patient, I was probably like, I don't know, 12 or 13 or something. Most of the time, people would go to hospitals to do them. So you'd go to a motility center, you would sit there, you'd bring a book, there'd be like maybe other people with you, or sometimes you'd have your own room if it was fancy. But you would be stuck there for hours, and the nurse or someone would come in, you would blow in this thing, she'd go away, and then she'd come back. So you were stuck in this place. And we've moved away from that recently. Not all the time. There's still like Cedars will send people to sometimes, but we have direct to consumer at home test kits now that we can use too. Then one step further is this new device. And so let's talk a little bit about the Food Marble. And there's a couple different models. I guess we can touch on both of them and what separates them as well.
Yeah, the Food Marble is, as you mentioned, it's a direct to consumer. It is an at-home SIBO test. And so it's this, I have the most recent one here, which is called the Food Marble Air 2 device here. It's just the palm for size, a little bit smaller than the size of your palm. It tests for two of the main types of SIBO gases, hydrogen and methane. Essentially, as similar to if wherever you're collecting your breath, you blow into this little device for 3 seconds, like you're cooling soup. And then the device registers that number, and it attaches to your smartphone. There's an app, and it collects the data and then sends it to your provider.
Yeah, super simple. We both have used them and use them with tons of patients. And it's only two gases though. So what's the other test that we'll sometimes use that looks at the additional one?
There's a test called Smart for tests all three, which includes hydrogen sulfide. And hydrogen sulfide SIBO is less common, and there's some characteristic symptoms of that, like sulfur smelling gas, that if we're more suspicious of that, then maybe choose the Smart over Food Marble. But in general, hydrogen sulfide is much less common than the main two, hydrogen and methane.
Yeah, I remember in the beginning when we looked at the hydrogen sulfide, I was testing everybody with it because I was like, I don't want to miss it kind of thing. And it is way, way less common, where you're not seeing it really commonly pop up, especially if cost is an issue. Sometimes it's not the best way to go, taking that into consideration too.
Yeah, certainly.
So you have the device. How many times can you use it?
You can use it over and over again, theoretically, infinite number of times. We wouldn't suggest doing it an infinite number of times. We want to use it purposefully, but it's reusable. So oftentimes we'll use it to make a diagnosis, and then after completion of treatment, so we can see how well the treatment worked. And then to which we can talk about, SIBO tends to recur. There's a high recurrence rate of SIBO. And so if we do need to retest down the line, we're able to use it.
Yeah, and I think that's what really makes it different from the other options, is that people were paying 90 or something, 300 for a test if their insurance wasn't covering it, and then having to repeat time after time because of the reoccurrence gets really costly. So it's a nice option to have for people. Let's just take a case. If somebody comes in, they have bloating, gas, they're burping, maybe they have either constipation or diarrhea. And it's one of the things that you want to cross off the list is SIBO. Let's say they don't have insurance, so we're not going to go through an insurance model, and you've decided to use the Food Marble. What does that look like working with a patient?
Yeah, so if we decide that we want to move forward with the Food Marble, we can go ahead and order for it. It'll get sent directly to the patient's house. The lactulose, the substrate that we use for the test, is a prescription. So we do have to send that into the pharmacy. And you pick that up from the pharmacy, you'll get sent the kit, usually arrives in about a week. And then there is a little bit of a prep diet the day before. It's essentially bland foods, chicken, white rice, fish is fine, eggs, but low fermentability. We're trying to get a good baseline. So day before is that prep diet. Have to fast for about 12 hours. So usually do overnight fast, and then people will take the test in the morning. With that, so fasting in the morning, there are a few limitations. No exercise, no smoking, things like that can affect the results. You start off with a baseline. So before drinking the lactulose, you'll use the device. It'll give you the okay. It'll tell you to take the lactulose, and then you'll continue with the test, which is mentioned every 15 minutes for Food Marble, and for 3 hours going into that. The app makes it super user-friendly. It has a timer for you, tells you when to take it, and we'll ask you a few questions about symptoms during that time. And that's kind of the crux of it.
Yeah, for people who don't like reading directions, I love the app because it literally just goes like stage by stage. Did you do this? Did you do this? Okay, here's the next one, which is really nice.
Yeah, I agree. I'm one of those people. And then the one PSA, which I learned, is that they do recommend they have you do a practice breath. So you have to do that the day before. And so that's helpful to know if you're planning.
Yeah, it's something you do have to prep for. That diet, I think, holds people back sometimes where they're like, I gotta go
Mhm.
shopping before. But pretty simple once you do it. I feel like the first time you do it, this isn't too crazy. And you're at
Mhm.
home, so you can be working between the breaths. It's not like you're stuck at this hospital where you can't do anything in between everything.
Yeah, I do tell people to not pick a day where they want to feel their best if they are going out later that night and wearing tighter clothing, or they have a presentation later that afternoon where they want to think clearly, because with the test we are triggering the symptoms. That's the goal of it, so that we can collect that, measure that gas production. I generally tell people to do it not on your biggest day of the year.
Yeah, great point. Lactulose being fermentable and potentially
Mhm.
causing those symptoms if this is what's going on. It's also a nice thing to be able to notice if you're getting symptoms during the test, it's more likely to be SIBO as well. Big question, is it actually accurate? Some of these at-home tests that we have aren't accurate, and that's one of the big things we want to make sure that it is.
Yeah, and this is one of the common questions I get from patients too. But Food Barber actually did a study in 2019 that showed that there was 100% concordance with the standard clinical device used, matched what you see if you were to go into the gastros and do it in hospital.
Yeah, great. And the nice thing about this device is it's not just applicable for the lactulose breath test. It also has another option, which is, to my knowledge, not validated. Do you know anything besides that? But what is it?
So not validated, because we don't have validated testing for these intolerances in general, yet it is more of kind of we're hypothesizing and seeing how you respond, and that supports our hypothesis or refutes. But essentially it's called intolerance testing. So they offer 4 FODMAPs: sorbitol, inulin, lactose, and fructose. And FODMAPs, which we have talked about before on a prior video, stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Essentially what that is, carbohydrates that are poorly absorbed in the small intestine, and they will move to the large intestine and ferment. When we ferment, we produce gas, and it can produce those symptoms. And so it's really common to be triggering in things like IBS and SIBO. So with each of these substrates that they send, the sorbitol, inulin, fructose, and lactose, we get to test individual types of those FODMAPs to see what you're most reactive to. For people who find benefit from the low FODMAP diet, it's still a very restrictive diet, and our goal is always to have as much diversity as we can for our health, but also for our mental health and just the freedom to eat what we want to eat. So being able to pick out and see if is there a specific FODMAP that you're most reactive to, or you react to and you don't react to the others, that can help us to expand that diet. The process is similar to the SIBO. So there is a little bit of a prep diet the day before. It's a low FODMAP diet, so we get a good baseline, and then you'll consume the substrate. Pick one at a time, and it is fasting day of, same as the SIBO testing. Pick one of those substrates and then do the baseline breath and then the full 3-hour test every 15 minutes.
This is really nice because it gives us at least a little bit of objective data, because otherwise we're doing elimination and reintroduction of FODMAPs, which is
Mhm,
purely subjective, where you're
mhm.
just saying this doesn't feel good, or I think I'm fine with this. And some people have a really hard time with the guessing game. I don't think this fully gets rid of that. I don't know your experience with patients, but I'd love to know what you say to patients actually. My like spiel for them before they do it is, hey, I think that this is useful. It's not validated yet, but it's better than nothing. And
Mhm.
we may get a ton of information from it, or we may not get a lot at all. But for the cost of it and the fact that it's not going to harm you, I still think it's well worth doing, because there are some people that get really important and like usable information from it. But I
Mhm.
tell people, if you come back positive on all of them, then it's not as much of a learning tool for us as if you came back for one of them. What do you
Yeah,
think about
yeah.
that?
Yeah, I do say similarly too. And one of the limitations is that we want SIBO eradicated before we do this testing. I reserve it for the patients who we've done the SIBO testing and it's eradicated, or SIBO treatment and it's eradicated, and you're still having symptoms. And I'm okay, here's the next step. What else can we see that could be contributing to these symptoms? And so that's typically when I do it. And it's oftentimes with the goal of expanding that diet, or giving people information so that they know when, again, if they have a big day and they tend to respond to more sensitive to inulin, that the day before or day of that they have more information about their food choices so that they can be clear-headed or not bloated for whatever event they have.
Yeah, so it can give a little bit of information. Ideally, we don't want to keep somebody on strict low FODMAP, taking everything out for a prolonged period of time. So it can be helpful in seeing you didn't score anything for inulin. Let's pull that all of those foods that have it back into the diet and then go from there. Another common thing that I hear people or they ask is, I did the lactulose breath test just with the packet that came with the kit. I don't know how
Mm-hmm.
it's happened to you, but why is that not the case? Let's like pull those apart.
Yeah, so the kit includes lactose, which is different than lactulose, the substrate. The two different things, they just have very similar names. And so if we're using the lactose, that's going to lead to inaccurate results for the SIBO.
Yeah, so the lactose is going to be what's found in dairy. The lactulose is the prescription that you can only get from a doctor in your pharmacy. So if you're looking to test for SIBO, we're looking at the lactulose prescription. It can't come with the kit legally. But let's go into that. So lactulose versus glucose. Can you tell me a little bit about the difference? Because some people will use glucose for testing.
Yeah, we've largely talked about a lactulose breath test, but you will see in gastroenterologists and with integrated providers too that they will use glucose as that substrate. Glucose does not require a prescription. So if in certain states where people are unlicensed, it is an option for using. We tend to prefer lactulose because lactulose is not well absorbed by our small intestine. So it stays in our body, it moves through the small intestine and feeds all the way through. So we get to see that distal part of the small intestine. Unlike glucose, which is well absorbed by our body, parts of it get absorbed through that process. So we don't get that full dose at the distal part of the small intestine, the end of the small intestine. So we can have false negatives. I will say there is debate in the gastro world of whether lactulose or glucose is the better substrate. Lactulose itself is a laxative, and so it can stimulate motility through our small intestine. And so there is concerns that if we have increased motility or increased movement, the speed of movement through our small intestine is quicker. That can lead to a false positive. Typically, when we're looking at the test, we look at around 90 minutes for that cutoff between what's the small intestine and what's the large intestine. And if something has theoretically gotten to the large intestine sooner, around say 60, 70 minutes, and we see a positive and we see that hydrogen rise, which is expected when we get to the large intestine, we can say that's a positive for SIBO, but it's not actually a positive. The lactulose has just reached the small intestine and we're looking at the fermentation in the large intestine. So there's definitely differing opinions about which one to use. I think the takeaway message is that we have to interpret it with your symptoms. And so knowing how you're feeling at certain points in times and how you present is helpful. Also important to say with SIBO, we're still in infancy of research. We have a limited amount and some conflicting evidence between different studies of numbers. And we'll mention some throughout here when we talk about recurrence rates and even the IBS and SIBO overlap. Those are still preliminary. We're still getting a better understanding, and we do need more research to get really to solidify and feel super confident in those numbers.
Yeah, I 100% agree. And this is why it's really helpful to have somebody analyze your results for you to say, this looks like a false positive. Like it looks like, did you have diarrhea that day too? What was your motility like? And to be able to differentiate between the lactulose being in the small intestines and being fermented at high levels or being in the large intestines where it should be producing more hydrogen in terms of fermentation. I think that's a really great point. And let's talk about not everybody with bloating, diarrhea, constipation has SIBO. So I think that's a really important point. And what different conditions can sometimes be misdiagnosed or look a lot like SIBO.
Yeah, so quite a few. IBS presents very similar to SIBO, and we have mentioned that we likely think there is some overlap between people with IBS and those who have SIBO, but it can be IBS sans SIBO without SIBO. Other things too, like celiac disease, Crohn's disease, and so want to make sure that you're not missing anything and just automatically treating SIBO. And the kind of aspect to that as well is that SIBO can present on top of those conditions too. Just because you have that positive SIBO test doesn't necessarily mean that everything else is now ruled out. You should still make sure that you're getting the proper workup to make sure that not missing any other conditions that would need to be treated.
Yeah, it's not uncommon to see somebody come in with Crohn's disease and also have SIBO. You can definitely have those two things. You can have IBS and IBD, right? Like you can have so
Mhm.
many different things to make sure that you're covering all your bases. Because this is where we see like people have self-treated themselves for like months or years, or they've seen a bunch of practitioners but haven't gotten to the root of it. And just having somebody who like mostly does GI, I think is really helpful here. What do you think are some of the contributors to SIBO?
We know a lot can contribute to SIBO. Some of the big things that we think about are things like motility, movement through the digestive tract. There's certain conditions, certain drugs that can affect our motility. Looking at that's a big one. Other things are anatomically, we can have things like strictures, which are essentially fibrous things in our small intestine that can lead to like blockages. We can have diverticulosis, little sacs or pouches in our small intestine. Even things like endometriosis can cause changes to the small intestine. So those things can be affected. Other things I think about, immune disorders. Our immune system functioning is really important for our digestive tract. And if we see impact there, as far as things like HIV, IgA deficiency, those can affect. And then another big one, hypochlorhydria. So low stomach acids. We see that with chronic PPI use, certain autoimmune diseases. And then metabolic disorders, things like diabetes, blood sugar imbalance, or pancreatic insufficiency, so not enough digestive enzymes, low bile, which is what our gallbladder produces to help with absorption. So any deficiencies there we can see contribute to SIBO.
Yeah, and a lot of the times we're checking for a lot of these when we're doing blood work and stool tests for certain people too. So we would see, okay, you have low pancreatic elastase, but you're also positive for SIBO. We want to make sure that we're looking at both of those as factors. We talked about reoccurrence a little bit. It's really common with SIBO. Do you have an actual number? I don't know if you've thrown that out yet.
Yeah, one day I found 45%. But again, grain of salt with we need more research, but around 45%. And I see that number reflected in practice. I think with our practice, we tend to see people who come with a diagnosis of SIBO and have treated it and had recurrence already. And yes, we see a lot of it.
So 45% of people who present with SIBO will reoccur after treating it, is what you're saying. And that's
Mhm.
definitely what I have experienced as well. It's very common to reoccur. And I think this gets back to the research is still ongoing here. Are there things that we're missing? Are there things that we should be looking at to get better results with it? But this is stuff that people are definitely looking into and we're constantly learning about. And we've come a pretty far ways from it, I would say. I remember when I was treated when I was like 12. It's definitely more robust now, what we know about it. Any other things that we should be thinking about when we're talking about the food marble or just SIBO testing in general?
Yeah, just highlight that SIBO can be a difficult condition to treat, and then working with the provider is super helpful. What I tend to see people walk in the door who've already been diagnosed with SIBO and have tried treatments, whether it's been from an integrative or a conventional doctor, is they focus on that quote unquote kill phase where they use antimicrobials, whether it be antibiotics or herbs, but there's focus on that kill, but not any of the contributors of what could cause it. And so you might have some improvement with that original treatment, and then we start to see it come back gradually, or just have an inadequate response to that original treatment. So finding somebody who is really going to go beyond that kill phase and really dig into what's going on is helpful. And that's what I find leads to the best, most durable improvements in patients.
Yeah, great point. Absolutely. And I'm going to go ahead. If you're watching this on YouTube, there'll be links below about just you can take a look at what this device actually looks like. And if you're on our blog, there'll be a link there as well. But thank you for putting this all together and explaining it so thoroughly. And we'll be back with another topic soon.